Good. Hello, everyone. I'm on joining today to talk about the MR fingerprinting and which is the mapping of the future and the personalizing imaging. As usually, let me introduce myself. Sorry, my name is Zeraii Abderrazek. I'm a neuroscientist, and now I'm working as a MRI clinical application in IGE International in Tunis with Siemens healthineers. So just some of you know me as clinical MRI, and I'm doing some research apart of my job. So, and you know that we are working together with the conventional MR, we work like some sequence and some acquisition, and it's so good. But most of these applications are a qualitative image. So we want today to talk about the quantitative one. So just before I directly go through the theory and the clinical application of the MR fingerprinting, I like to show to you a very simple example here on what the difference between qualitative and quantitative measurement. So when a kid feels not good at all, and we want to check if there is a fever or not by simple touch on the front hand, right? And to tell us it's warm or cold. So, but the problem here is the feeling is a very subject one, and we should visit a doctor to verify, right? So the doctor for sure will be use the thermometer to have a number, and this number it's the first step to make an initial diagnosis and to plan the right treatment. So this is the number, and yeah, we make sure that it's warm code, but when we're using this thermometer, it will tell us some numbers. And of course, rounding this number will make some plan of treatment. So on the other hand, this is an example, but a real example from life. But when I'm talking with MRI, we talk about some sequence, this flare or T1 or T2 or proton density, whatever sequence, we look and we visualize some structure and some subtissue. So I think today, it's lovely to say that all people here from different country, especially from low and middle and income country, are very passionate about MRI imaging. So, because it's already a method that have the potential to answer about many cases on the radiology field. So I want to show you a case here on this region. We say bright, right? This is what we called MR hyperintense. So we could ask already different question if it is a disease severity and we can reproduce this image. So if we see here the brightness, we should ask if it is a disease. The answer it's too bright, right? But the answer is no, because it's a subcutaneous fat that located here, and it's not a disease. And we are asking together if can indicate a severity of this brightness. We don't know because we don't have measurement, right? So day in day and day after day, for sure, the numbers don't mean much anything. Okay, that's relative numbers means something but absolute values don't mean much anything. I want to make an argument here that actually have real numbers for those value T1 and T2 and proton density would allow us to make a better decision, right? But we know that's very difficult because to work on the quantitative MRI, it takes a lot of research and a lot of work and many times. So the diagnosis will be very long and depend a number of examination and of exam scan, right? So this situation, like we talked about, lead a different issue every day. So if we get an image here, like this one, it always thinking on different strategy. And like for sure to compare between some image it's like to ask a question: is it a metastasis or ependymoma or a glioma or meningioma? And if there is a glioma, it's low grade or high grade. So we ask many questions and to verify with other different questions with other different sequence like diffusion, like the dynamic susceptibility enhancement or contrast enhancement or whatever, and neuroperfusion to start and everything. But let the radiologist take and be sure about which these lesions are. So I think this situation, like I said, it's very difficult to differentiate between this type of tumor. So the right answer and the right so in order to determine which tumor we have and which level of tumor we have, always the radiologist needs to send their patient to have a biopsy, right? And which usually very complex process and hugely invasive, and it's very expensive. On the other hand, because here I mentioned an example that in the United States of America, the biopsy, the price of the biopsy can go from $3,000 to $12,000. It's very, very expensive, and it's depending on the country if there is the the potential to have this biopsy and if there is a dedicated service to have a biopsy. So it's very difficult, right? So, and for sure, every biopsy, it's a failed imaging experience because it can cause difficult. For example, when some people like to say or like to have a biopsy for the spinal cord, it's very difficult and very hard to the patient. So, this is what I'm talking about. It's the fingerprinting. I related the MR and the fingerprinting, right? So let's start by the fingerprinting. So we get back to the use of the name of MR fingerprinting, and that's really seems like to the conventional fingerprinting of the FBI. So if you think that's this random series, that's a random series with black and white markers on the image, but are actually we can get information that we are talking about. It's matched to a database with previous fingerprints and to lead to the names and the phone address or whatever, or the person, like the FBI search on, right? So MR fingerprinting is the giant leap for the precision in medicine. So MRF use absolute quantifiable to generate a more precise understanding of patient condition. Quantitative MRF offer enormous potential to enable less invasive diagnosis by identifying morphological change that can contribute to therapy decision and treatment evaluation. So in clinical routine, we use in general the scanner more than like a camera to produce image, right? So images are affected by multiple parameters by choosing certain sequence, certain reconstruction method to produce different contrasts such as T1, T2, or proton density. And this concept of weighted imaging has been very successful in MRI, but still only for visualization. So if you look at this image here, for example, it's a 2-2 image weighted image. It contains a lot of information between the gray matter, the white matter, and the cerebrospinal fluid. So you can distinguish the different tissue here based on the brightness of the tissue, but the actual intensity don't mean much, since that we know that when we repeat this examination on different scanner, we can get some different color of the brightness. So to repeat the exam on the same scanner or to change the scanner between the same field change, same field of the scanner, so we can get different contrast, right? So now with quantitative MRI like here, like this T1 map, no matter where you have scanned your patient, all will be the same value, and the same contrast as well. And this is very benefit for to the quantitative MRI. So the MR fingerprinting is a novel concept for quantitative MRI, and it arrived to overcome the limitation that we talked about. In fingerprinting, signal or fingerprints are required using a special excitation, and this kind of accusation, the sequence parameters such as flip angle or time or repetition time TR parameter, and these parameters are the same during the accusation. So we can use this number of parameter and change them during the same accusation. Then the same accusation is simulating, and the results of the signal of fingerprints stored on the MRF dictionary, and then the accurate signal is matched to the database of the fingerprints, and this process, the more fingerprints is identifying and by sorry
it's I think it's
yeah, okay, let's move. Yeah, and the most fingerprints are identified and by that tissue parameter. We do this for every voxel. We do this for every voxel on the image, and you get the magic parameter, quantitative parameter, and the quantitative maps, right? And since they are all estimated from the same accusation, so we don't need to do the registration. So all maps are perfectly aligned, right? So this is an example of fingerprinting accusation. So this is an accusation that the first time was published on Nature journal that used a sequence. It's called TrueFisp, which is a gradient echo sequence based on balanced steady state free precession. And here is the modification of the flip angle and the time repetition during the time, right? You see there is a modification during the signal process, and you look on the right, there is the spiral reconstruction of the K-space, because in the conventional MRI, we talk about the Cartesian. So if we talk about the Cartesian reconstruction, that we fall off the K-space, if we can get like image like T1 or T2. And there is also the blade accusation that we talked about. It's a radial accusation and the radial reconstruction. And here just in MR fingerprint, we talk about the spiral reconstruction, right? So if you look now at the signal, on the voxel, we choose some voxel here on the reconstruction, it's not very smooth. You see here, it's not very smooth. It's generated a lot of undersampled artifact, right? So this signal is compared to the dictionary, and the dictionaries look like it's more, yeah, look like it's more smooth on this case, and there is no undersampled artifact. So which is created by assimilating on the same sequence, and different fingerprints here are simulated for different combination of T1 and T2 and proton density. So once the match is performed rightly between the fingerprint and the dictionary, in this case, the sample artifact is incoherent for the best match, and can be found right like we talked about on dictionary. Here we see the first signal on the previous example, and we see there is artifact of undersampling, and now it's perfectly aligned. So here is we talk about the map generation. So in order we get the signal, we compare to the dictionary, but the final objective is to get some maps, right? So if it's performed to every voxel on the image to the comparison of the accurate signal with the dictionary finding the parameter, and we can extract from this signal a parameter or a map like T1 mapping or T2. So in order to get this image or those mapping like T1 and T2 for the same acquisition, that's on the conventional MR, we modify different parameter on the acquisition, on the contrast, on the resolution, and also for some sequence, for example, T1 or T2, there is a lot of change on TR and TE and the flip angle. There is a lot of parameters. But here we can change only 2 or 3 parameters and RF pulse and on the same acquisition, and we get 2 different map. The conventional MR is to choose different parameter to different property tissue type. For example, we choose T1 cartography or contrast, and we change different time and to get around 2 minutes or 3 minutes to get a T1 contrast, and another sequence to use different parameters like TR, TE, flip angle, and so on to get another contrast T2, right? And on this technology, on this novel technology or on MR fingerprinting, just we modify a different parameter and we use trophy sequence, and we can get 2 different maps, and we can also get other maps like the proton density or like proton density, right? So the only requirements that the sequence is very general. So we want temporal incoherence, which mean different tissue type and different tissue to look, which I mean to look different to one to other, and we want a different spatial location, right? To look different from some voxel to other voxel, right? So we achieve the temporal incoherence by modifying the acquisition parameter. So each tissue type has a unique signal evolution. And we can achieve the spatial incoherence in the MR fingerprinting by modifying the spatial encoding inside the sequence. And this is we get by a randomized spatial encoding. And this for sure can lead to no aligned signals appear as a random noise, right? So this is a very general requirement. So the first sequence looking like this one by using an inversion inversion recovery sequence, which is a gradient equivalent sequence. It's trophy span, and here we see that we're modifying during the same acquisition. We modify the flip angle and the time repetition to get with, and for sure we go with the spiral reconstruction to get image like T1 or T2 or density protein. So in our acquisition, we need a database that contains a range of biological tissue like T1 or T2, and we know in which sequence we run, and can be used with a very wide range to put all together on the block equation to get a signal pattern for different signal, and to look this one with different signal tissue type. Like here we add the parameter of the tissue type. We add some sequence of parameter like we talked about TR and the flip angle and so on, and to put all together through the simulation of the block equation here to get those signal, right? And these signal are the standard one like the fat or the Y matter or the gray matter or CSF, cerebrospinal, or whatever. So here the problem of the conventional MR, it's when we try to use some scanner like high field or ultra high field like 3 Tesla or 7 Tesla like Siemens use, for example, the Vida or Lumina 1, and try to enhance the spatial resolution to find some structure on the neuro examination. For example, for the Terra X1, it's for the 7 Tesla. Maybe now the Siemens and the Northpin Institute work on the IZOT project. I don't know if you understand, if you hear of it or not, but they try to use the 11.7 Tesla. But the problem is to create some homogeneous signal. And this is on the conventional MR. this on the MR fingerprinting, we can use this physics, and this physics can really help because we have two parameters and two way. It's by the temporal incoherence and the spatial incoherence, and this is very benefit by using the MR fingerprinting. So you can work with MR fingerprinting on whatever field you use, for example, for 1.5 Tesla or 3 Tesla or 7 Tesla or whatever. So the MR fingerprinting will be very useful and very interesting on different field. So here I give you an example. Here we can work with the magnetism solar, with the biometrics or whatever, the 1.5 field, 1.5 with the Tesla, and the 3 Tesla also can work with the Tera 1 on the 7 Tesla. So just to mention, that's the same sequence could be running on different chip machine and with different field strength, and exactly the same sequence, but with different signal inside the dictionary. It's dependent on the type of machine, right? So to some high field on different field like 3 Tesla or 7 Tesla, an image present an homogeneous contrast like the black here, you see. And one of the advantages of the MR fingerprinting, we don't require the homogeneous field at all. So we require is to know the B1 field. It's just to know the B1 field. And this is a 3T B1 value at the same to have a good contrast and good quantitative map between T1 or T2 or proton density. So on the conventional MR, we have a lot of problem and a lot of issue about the homogeneous contrast, and sometimes we need to use the shimmy and so on, but sometimes it affect the quality of image. So on the MR fingerprinting, it's a very useful and very quantitative method. Like we have this quantitative image B1. It's the RF pulse B1, and after that, the sequence it's already can correct it themselves by, and we get a good image map without artifact and without imperfection. Like to be more engaged on the clinical routine regarding the application of the MR fingerprinting, Siemens Healthineers, it's working very, very closely with different team of research, and this is an example of 2D MR fingerprinting product scan available on the Vida scanner. So each voxel, and each single slice can take this time around 20 seconds, and for sure for a resolution 1 by 1 millimeter. So and there is no need to change the acquisition parameter, so we can get different tissue type like T1 or T2, and for sure it's a good resolution for 2D. So there is also a dedicated work to get 3D MRF to provide different tissue type, including the proton density, and for sure with isotropic image resolution, as well with the segmentation of the gray matter, wee matter, and cerebral spinal fluid. And this is a good example. And if you can just, because we have an isotropic resolution, and we can get our image in different view angle, like axial one, or coronal, or sagittal one. So this is very important to work with the 3D sequence. So here is an example, an quantifiable example like of T1 and T2 and proton density, as well at DC1. Like we can get this image simultaneously from a single slice and a single acquisition and single scan. And there is also the other parameter like CBV. Like in the conventional MR, we work with neuroperfusion T2 star to get this image. Also, there is the radius image and the saturation of oxygenation and some statistic parameter. This work is it's the fruits of working between the team of Stanford University and Siemens Healthineers. In addition to providing different maps and different multiple tissue property, MRF allow us to provide those map with confidence map like B0 and B1 imperfection at the same time. And the study performed the ultra high field quantifying T1 and T2 as well, B1 and the density protein weighted image. You know, that's in the ultra high field, the B1 can be more severe as compared to the low field. So it considers this imperfection of B1 on the signal, and we quantify it with a signal property, and the result will be less affected by this imperfection and homogeneity. So just we get this image and we try to use this map and this map to correct our image and our imperfection to get a good quantitative map. So a part of neuroimaging, this technology can also be applied on different clinical application part and body part for sure, including the cardiac. You see here, you know, that's on the conventional MR, like we talk T1 or T2 or T2 start to quantify the hemochromatosis or to quantify to see some disease on the cardiac. We know that's maybe we can work on conventional MR with T1 and T2 star and T2, right? But here we can apply also as well the T1 and T2 and the density protein of the scan of the cardiac, right? And also we can work on the liver as well for the fat quantification and the iron quantification as well, and to get some image like T1, T2, and density protein. So maybe also we can use this technology for the breast imaging, and we get the same image with different tissue type. Also, we can work with the HYPE imaging, also with different contrast and different mapping to characterize tissue type. So okay, now we have numbers, right? Like we talked on the first slide. And we want to test the reliability and the repeatability between these numbers. How to use numbers to address clinical question, right? If we found, for example, 39.2 Celsius degree, it's already, this number indicates something. In terms of detection, as this number can be more sensitive to identify a subtle lesion and for tissue characterization. We have multiple tissue properties. Can we use this number to differentiate lesion, right? So we want to ask in our methodology, could give a better diagnosis for better treatment. And I'm going to show you some clinical case, like to understand better what is the uses of the MR fingerprinting and how to differentiate between the MRF and the clinical and the conventional MR, right? So in this study that on were applied 3D MR fingerprinting from a team from Cleveland for epilepsy patient scan. So this epilepsy patient has heterotopia, lesion around the ventricle, where we can see on the conventional scanner, right? Maybe we can see it on the FLAIR image. But the key problem is which part of the lesion make hard seizure, right? That's really hard to distinguish on the conventional MR. But we look up on the T1 map for the MR fingerprinting, we conclude that there is a significant T1 increase here for the corner of the lesion. And this is a new finding from the MR fingerprint that's not shown on the conventional MR. So on the conventional MR, we make sure that's on the FLAIR image or the T2 image, we see there is a lesion, okay, but we can't estimate this number and can indicate something. After that, the patient undergo an EEG evaluation, and it's already validated the location, the right location of the seizure. So in addition to region detection, okay, we have detect the region on the seizure, but now we have this quantitative map and already a multiple quantitative map like T1 and T2 and the proton density. So we can use those numbers to characterize this lesion. So here you could distinguish between no epileptic nodule and epileptic nodule, and for sure the white matter and the gray matter. And this plot of T1 versus T2, this T1 versus T2 scatter plot, and we can conclude that epileptic nodule, it's more sparse, it's a distinct cluster here compared to the non-epileptic nodule. And of course, this is not shown on the conventional MR. So another patient started with the same case, which mean epilepsy case, right temporal, it's on the right temporal epilepsy. From the conventional MR, see a large amygdala here, but for T1 map on the MRF, for the T1 map on the MF, we could identify clearly this is spatial tail extended. There is a tail here extended from the gray matter to the white matter. And for the calculating of the gray matter fraction, and here, and we can zoom through it, we can see very subtle lesion is highlighted here. We can see here that's the lesion is very highlighted, and this one we can get by annulling or deleting or just to remove the contrast of the white matter. Just we keep the gray matter lesion. So can we see here very clearly there is a tail that it extended from the gray matter to the white matter. So again, this is not be shown on the conventional MR, and this can promote or to advertise us or to think about the utility of and the importance of the MR fingerprinting through the epilepsy case or through the neuro case. So apart from neuro, T1 and T2 from MRF here belong to ADC, can be used to characterize prostate cancer disease. So because we have now T1 and T2, also the ADC. So numbers, we can do multi-parametric. So we can do multi-parametric analysis, and this is a plot between T2 parameters also and ADC, and here we can distinguish very clear between the normal peripheral on the prostate and the low grade. Here we can see here the low grade and so on for the high to end grade cancer, right? In the conventional MR, just we verify the T2 conventional, and we see another parameter for the DCE map to see the evolution of the contrast product through this lesion, also to verify on the diffusion weighted imaging parameters. So on the conventional MR, we see multiple parameters alike, and we see the enhanced image to detect if it's normal or high grade, or low grade, or high grade. So on the MRF, it's very distinguishable. That's maybe just we use T1 and T2 and the ADC value to characterize and to put the prostate disease or the prostate cancer disease on some level, right? In addition to the disease characterization, we can also use this quantitative map and numbers to characterize the development of or change over time, right? So here on our study from the Department of Radiology, using T1 and T2 and the Myelin water fraction map in order to see the change of the case from the 6 months to the 52 months And we see the number are changed, and those changes are directly related to the tissue property. So it's very, very important if maybe if we can monitorize some patient or some new babies or whatever. So maybe we can use just three parameter or three map that all, and the benefit here, it's all from one sequence, and it's very rapid sequence. This is the important if we choose 2D sequence or 3D or whatever. But one sequence we can explore to three or two or three or more parameters. Like so, here another example just to mention that maybe we can use the T1 conventional weighted imaging or T2 or the contrast after injection of gadolinium or whatever, just to conclude here, just still the same meningioma, right? So, but how to differentiate the type of meningioma of meningeal cell or the transitional or a fibrous meningioma. On the conventional MR, we don't have the ability to change this type, sorry, and to understand in which type we are. But based on the T1 map and T2 map for the MR fingerprinting, we have numbers. And when you have numbers, you could for sure subtype or differentiate the level of the meningioma. So here another case from the neuro, and just we use the conventional MR to see the macroadenoma on the pituitary microadenoma. Just we here on the different views like coronal or sagittal here and the axial here, we see the macroadenoma. But how can we differentiate between gonadotroph pituitary macroadenoma and no gonadotroph pituitary macroadenoma? And this is very important by using different tissue type like T1 and T2 mapping, and this number can indicate in which level. I think that's by the repeatability on the scanner and the number of different exam scanner, we can distinguish between these two types. So also we can apply the MR fingerprinting in the brain tumor, like we talked about the meningioma, and there is also the most dangerous case from the brain tumor is the glioblastoma. So maybe here we see on the FLAIR image, like you went to the lesion, and here we see different case of the glioblastoma and different contrast image, like here we see like FLAIR image, here like a T1 image injected with a contrast gadolinium, but here we can see the different value of this region. It's very important to put some region of interest through this image and to get some numbers. And this is very important to characterize the glioblastoma. So here, like I said, just on based on different tissue type on the MR fingerprinting T1 and T2, and based on different numbers, we can quantify, or we can separate, or we can classify the different grade glioma between grade 2 and metastasis from lung cancer, just by the repeatability and the reliability of the scanner and of the sequence during the acquisition and during different case on the glioma. So we can separate which type of the glioma we can have here between the grade 2 and the metastasis from the lung cancer. So it's very important, because in the conventional MR we cannot for sure we cannot distinguish which type of the glioma, right? So here there is different mapping here. That's the conventional one, and the team, they are trying to use some different region of interest to conclude if there is an infiltration or edema or normal. And this is very important on the T1 and T2 mapping on the MR fingerprinting. And here we can have a plot that identifying T1 mapping, T1 value, and T2 versus T2 value on the scatter plot. And here we can separate by the region of interest between the edema and the tumor, which is tumor under region area 1, or tumor under area 2, or tumor under area 3, right? And here maybe you just make sure that we put the region of interest on the right part of the tumor, and we can conclude which is an edema. Here, when you look at the yellow region of interest here, you look here, it's very distinguishable that it's an edema, right? And when we use the green one or the red one, it's apparently it's the right tumor. And maybe here we can conclude and differentiate between different tumor area, also as well from the contralateral side, which is the normal one. Here, it's the normal one. So at the same time, just we use the MR fingerprint with different acquisition from the conventional MR, and here we use T1 and T2 mapping just to look at which type of the diffuse of white matter damage and the white matter control. So here, maybe we can put the region of interest with the red one. It's indicate that there is a damage of the white matter tissue type. And when we put the region of interest of the green one, it's indicate that is a white matter of the controls. It's apparent very greatly on the T1 and T2, just here to make the correspondence and the overfit between the MRF and the conventional one. And when we make different region of interest, we can separate here from the T1 versus the T2 scatter plot. So this is another example, like we use different region of interest of a tumor, and just we want to search the infiltration here, and it's apparently it's in this zone. So it's very, very close to the tumor, which indicate different tumor, which is on the green one, it's the enhanced tumor, and peritumoral on the right, on the red one, and for sure the peritumoral far edema for the blue one. Just and the contralateral side, it's apparently here on the T1 or T2 or the conventional MR, it's contralateral region, which indicate the normal side. So regarding this sequence and this novel sequence, it's very important. It's not applied, which talked, it's not applied on different institution and different center and different, if it is a public center or a private one, it's already on the research and already on some clinical research users, like we talked about on the Stanford University. But Siemens put this MR fingerprinting development kit to download from this website of Siemens Healthineers, and we can run it by different sequence. And there is another kit to have this sequence in order to get the simulation or to get the acquisition from different parameter, like we talked about through FISP sequence with different variation of TR and flip angle. And we put them together with a toolkit from Siemens Healthineers. We can download it from Siemens Healthineers website with a free version, and we can run this sequence to get this image. And that's already makes sense to some institution on whatever they work on the neuroimaging or breast imaging or HIPE imaging or liver or prostate, whatever. We can distinguish and we can get some image like T1, T2 or proton density in order to characterize and in order to classify some grade of tumor or whatever, or to see, to confirm, or to confirm the conventional MR, to confirm that it's a normal region. And this is very important, and to get away from the biopsy, because like I mentioned, the very bad and the very hard experience from the biopsy. So get away from the biopsy, get your MR fingerprinting experience, and enjoy your work, and yeah, and enjoy your experience. Thank you very much. So hope you are enjoying this session, and I'm here for some question maybe you talk about. Thank you very
Thank
much.
you, Abdi. There's a few questions in the chat already, so
Yes,
maybe I can read them for you.
yeah, I will. Yeah, okay,
It
go
was,
ahead.
it was a great talk. Thank you very much. It was very clear. So there's two questions from Harrison. He's asking, can the fingerprinting be used for brain MR alone? And
Mm-hmm.
is fingerprinting like a sequence you have to install in your MR?
Yeah, for sure. I said, we can use MR fingerprinting for different clinical application and different part of our body. So we can use it for the brain, and we see that some example that to differentiate between different glioma, or to see the infiltration, or to classify the grade glioma, right? And we see another example that talked about the epilepsy and how to see the detail that are extending from the way matter, the gray matter to the way matter, and these value are quantifiable. There is a good use for MR fingerprinting for the neuro, also for the cardiac, liver, and prostate, and other part of the body, and this is very important. And for the answer for the second question, it's this parameter inside on MR, whatever. So we can use this MR fingerprinting sequence on whatever high field of for field scanner. So we can use on the 1.5 Tesla or 3 Tesla or 7 Tesla. So just a sequence, through FISP sequence, like echo gradient sequence through FISP, and just by modifying and put them on the sequence, and to modify the time parameter, the repetition time, and the flip angle, and the ref pulse, and we can download the rest or the third part of the toolkit in order to have this mapping. Hope I answer your question.
Thank you. Then James Gitongandungu is asking, what is the sensitivity and specificity of MRF compared to conventional MRI?
Yeah, this really a good question. This sensitivity or specificity, it's like metric, just to distinguish between different. If I use, for example, the MRF for the neuroimaging, and to separate and to classify the grad tumor between low grad or metastatic. It's very important to work on some parameters or some metric like specificity and sensitivity. And by experience from some teams like work on Oxford or Stanford University, and different university, they mentioned that there is a good specificity and a good sensitivity to work with the MRF in order to compare between different tumor on the brain or different tumor on the prostate, right?
Okay, thank you. Then the next question from Emmanuel Amaglo. He asks, what is the variation of spatial resolution and SNR between MRF and conventional MRI? Which I guess is a similar question.
That's a good question also. Like the conventional MR, we have the conventional the definition of different parameter, like we modify the time repetition, or the time of echo, or flip angle, or the resolution. We augment, we enhance the resolution, or the down back the resolution, and we regarding the SNR of the signal of the SNR of the contrast, right? And in order to for example, to have a good resolution, just we look a shutdown of the signal, right? Or to have a reduction on the resolution, we show that the signal is good. But here, just we look different way, different strategy of the acquisition. Like I talked that we use different parameters that are simultaneously modified during the signal acquisition, and the problem is the undersampling artifact. And this undersampling artifact, we can remove this undersampled artifact by using the spiral reconstruction, and this is very good for the image. So we can get this image with a good quality and with a good specificity and sensitivity, in order to be sure or that this T1 mapping or T2 mapping or the density protein mapping are very high performance in order to answer for some question if there is a glioma or whatever. So we don't work like on the MRF, on the conventional MR. It's a different strategy, different tissue type imaging. So we don't need to just to look on the signal to noise ratio or resolution or whatever. So just it's a different method. Like we are be sure on the T1 tissue property and T2 for some biological tissue, and we are sure that this mapping are already true. Yeah.
Okay. Then there's another question from Jamel Ramdani. He asked, how is the TR changed during the acquisition? Is it like a variable refocusing angle 180 or what?
Yeah. Yeah, good question, Jamal, because on the conventional MR, we work like to have a separate T1 contrast, right? And we put to choose the TR, for example, for T1, it's under 700 millisecond, and 42 just to work with a TR superior to 2000 millisecond. It depends on the sequence, right? And the utility here for the sequence, for the trophy sequence for the MR fingerprinting is just one acquisition, one single scan to get different tissue type, like to get T1, T2, and density protein, right? So the utility of differentiating between TR or modifying the TR, it's to get different tissue type, like on the first acquisition, like on the beginning of the acquisition, maybe we could modifying the TR to, for example, to 700 or 600 to get T1, and in the middle of the acquisition, just to varying the TR to get, for example, 3000 or 4000 to get T2, or inside the middle or the end of the acquisition, just we modify this TR to have different TR to get the density protein in order for sure with different echo time. So to get different contrast. And this is the utility of different repetition time on this sequence. And for sure we can modify it because it's a dedicated sequence and parametered on this way.
Okay. A lot of people are saying that it was an interesting talk and that they're thankful. If anyone else has a question, feel free to unmute yourself to ask. And if not, we can end it here. And just to say it again, the recording will be uploaded to 4Waves, so it can be later accessed if you want to look at it again. And yeah.
Yeah, thank you so much. I think it was well explanatory from my end. I really appreciate you, Abdul. Thank you so much. I can see a lot of guys, they really enjoyed your talk. Yeah, from my side, it's perfectly good. Thank you.
Thank you very much. Thank you very much.
Well, thanks a lot. It was a really explanatory talk, so I really enjoyed it. And see you soon in the AI lecture.
Yeah.
Thank you.